1, 2, 3, come on.
Hello, good night, and welcome to another week of Up for Discussion. On this week's topic, we'll be talking about mental health and its effect. We have our esteemed Dr. Geoffrey Walcott, MBBS, DM, consultant psychiatrist and clinical director for the Psychotherapy Associates Limited. And he'll be the guest for tonight. On the panel, we have Nadia McKenzie, Tiana Douglas, Denzel Harris, and Dimitri. Tiana?
Okay, so Doc, we've noticed that over time persons have a lot of questions as it relates to mental illness. A lot of us are not really educated on the topic. So my first question to you is, what exactly is mental illness?
Okay, well, first of all, thank you for having me on the discussion. Mental illnesses or mental disorders are really disorders that affect a person's ability to think, process emotion, or act in a social sphere. And there are a whole host of different categories of mental disorders that you have, from thought disorders, mood disorders, to behavioral problems. But all of them have a core in that they impact the person's ability to form healthy social connections, and they can either cause distress and or dysfunction in the person's life.
Okay. All right, so jumping to the second question. What does it mean to have a mental illness, and what are some of the warning signs of mental illness?
Okay. Well, if you look at it in terms of the most common illnesses, certainly in our country, what we found is that things like personality disorders are most prevalent. And these can be categorized as behavioral problems, where persons have what we call fixed maladaptive behavioral patterns. And they tend to act normal, tend to be able to go about their daily lives. But when they come under difficulty or pressures, then they are not able to adapt. And so they end up in distress when they are faced with any challenges. What we call, they have very low resilience. And so the distress and dysfunction tends to happen in these cases. The other categories are the anxiety disorders, which is really a fear response that you have that is coming on at an inappropriate time or without appropriate triggers. Because our fear response is normal, it helps to protect us from danger. But when it comes on at a time when you're not in any danger, then it can be a problem. And of course, you have depression, feelings of sadness, feelings of loss of interest in happy life. And then finally, you have the mood disorders, such as bipolar disorder or thought disorder like psychosis. So all of these illnesses impact the person's ability to function in their daily lives, and they cause some degree of distress.
Okay. Question.
Yeah.
What do you think most, like not most, some females probably suffering from mood disorders?
Well, we do have a high prevalence of mental disorders. In this country, the prevalence rate of personality disorders is something like 40%. And when you think about personality disorders, what we found is that there were three main categories. Person that had problem with power management or had constant conflict in their lives, person that had dependency issues, and person that had psychosexual problems. There are some disorders that have gender disparity, where they are more common in women, for example, borderline personality disorders. But most mental disorders are evenly distributed across the gender divide.
Okay. Awesome.
Doctor, remember when you were talking about anxiety and depression? For me,
Yes.
like what I found a lot here, because I live in the UK, what I found a lot is that people are not being allowed to process certain emotions. So like when people go through death or a loss or something, people are not being allowed to grieve, to grieve that process, after a while, people are start being clinically diagnosed. You understand me? To say that they've got depression or this or some anxiety or some mood disorder, but it's not really a mood disorder. It's that this person has gone through something tragic and not been allowed. Is it the same way that's been happening in Jamaica?
Well, I think that controversy is global. There's been a lot of work on identifying what is a normal reaction to tragedies of life versus pathological illness. I think one of the dividing factors when we look at either category is really whether or not the person is functional. Because even if it's a normal grief reaction, if you're not functioning, something has to be done. If you're not able to go to work, if you're not able to take on your responsibilities in your family, even if it's a grief, you're grieving the death of a loved one or some tragic event. The fact that you're not functional means that an intervention has to be put in place. But it has been a problem because the issue is, what does that intervention look like? If you have someone, I think it was Derek Summerfield at a conference that once said, if you have a man who is a farmer who lost his farm and he's now depressed, is his therapy putting him on an antidepressant or giving him back a farm? So it's a complex issue. And certainly we recognize that the management of what we term mental disorders is very complex. And it's not just a pill issue. We have to look at the social context, the psychological context in which the illness is being presented, and we have to help the patient maneuver that social context and that psychological space so that they can become resilient and learn to actually be more able to maneuver down the line. So it's a difficult situation because most mental illness do have a compilation of tragedy or trauma.
Question. Finish now, yeah?
Yes, I'm finished.
Okay, the word normal, we have been using that quite a lot. Could you explain? Because from
Well,
the streets, normal is, I guess normal can be to each person different, meaning different.
no, I
Each
think
man normal is different, because a person who is not in mental illness or in mental health field, a man who in the street talk to himself, wanting no answer, him think saying, right, all right,
probably
You
does,
understand me?
and it probably is. We don't use the term normal because we recognize that there's a lot of variations in human culture.
Mhm.
And so some cultural practices may be completely abnormal to some people. And so when you look at the diagnosis of mental disorders, we have to put a sort of caveat on it that says that the behaviors are not in keeping with what is expressed in the social, cultural, or even religious norm of the patient. So we have to bear in mind that there's no real normal because human beings are very quirky creatures. And so different cultures may have different practices which may vary widely. And so you cannot just establish a diagnosis of mental disorders without taking into context how that person relates to their cultural group. And I think the main issue is not just about symptomatology, but functionality. Because you can have persons who have symptoms of a mental disorder, but they are highly functional. And so you don't diagnose them as being mentally ill. They may be eccentric or having some issues. But functionality is really the most critical thing, because if the person is functional and not having any distress, then by definition you cannot diagnose a mental disorder.
Okay, makes a lot of sense. Other question though. Does diagnosis, so what you're saying in a nutshell, that diagnosis somewhat different is different because depending on different social background or different cultural background and such.
Yeah, you have to be, so there are certain disorders that are specific to certain cultures, as well as the way common disorders present may vary. So let's take a simple thing like in kids, and a disorder like depression. depression does not present in children in the same way that it does in adults. In adults, a depression presents as sadness, loss of interest, lethargy. The person is tired all the time, social withdrawal. But in children, a depression can present as violence, that the child becomes agitated, aggressive, and violent. So you recognize it's a same disorder, but the presentation is different because of the difference in age group. And similar thing can occur in terms of the different cultural aspects. Um, so you have to really dissect everything that's happening, what we used to call the phenomenology of the patient that is in front of you. And you have to really dissect it carefully. That's why it takes so long to do a psychiatric evaluation, because you really have to get into a lot of details and carefully place all the things where they're supposed to be.
Okay, understand.
Okay. So, well, question I had was, how do you diagnose someone with a mental illness? But as opposed to going to a medical doctor, and coming to you as a consultant psychiatrist, why would that be necessary for me to come to you as opposed to a medical doctor?
Well,
I mean, would a medical doctor be able to say that this case is a mental illness case or a mental disorder or something?
well, most general practitioners are able to recognize that there's a mental illness. But in regards to doing a thorough psychiatric evaluation, that really has to be done by the specialist, because that's what we're trained to do. But the issue of diagnosis, you really look
Right.
for changes in behavioral patterns. Mental disorders are really diagnosed when there's a change, and a lot of persons don't recognize that if somebody has been acting a particular way for their lives, no matter how weird it is, it's highly unlikely that they are mentally ill. But once you have a change in the way they are behaving, that's more
Mhm.
indicative of a mental illness coming on board. Whether it's changes in their social patterns, changes in their mood processing, changes in their thinking, memory, changes in the way they relate to themselves or each other, changes in the way they relate to their jobs. Once you have recognized a change, then it's indicative that something is going wrong, and you have to do a full evaluation to help that person recognize what it is.
Okay, so does the change have to be very drastic though?
Not usually. And some of the earlier signs we recognize is sleep changes. Changes in sleep pattern are one of the earliest signs of mental disorders. For example, in depression, what tends to happen is that you tend to get what we call middle insomnia, where you go into bed early, and then you wake up in the middle of the night and you have difficulty getting back to bed. If you're anxious, you might have difficulty getting to sleep at all. And if you're bipolar, you don't sleep at all. So sleep pattern changes can be subtle, but easily recognizable.
Okay.
Okay, we're going through a COVID epidemic, but it's still a pandemic.
Pandemic.
It is still a pandemic.
Okay,
It's the whole world.
yeah.
Right.
What disorder has been very pronounced since March up until now?
Depression and anxiety have come on very strongly, and they have been very rampant. There are some studies that show that actually post-COVID, that persons who have been infected are more likely to have symptoms of depression in the long run, as a sequelae of the illness itself. But most persons, whether they've been affected or not, are undergoing some level of depression or anxiety because their entire life has changed. In other words, you're looking at
Yeah.
persons now who are no longer able to chase their dreams, but they are just trying to survive. And so there's a shift in the way we view life and we view the world. And then you have restrictions in socialization, restrictions in entertainment. So persons are under immense pressure and there's no outlet. So what you're seeing is that the the prevalence of depressive disorders and anxiety disorders has got really, really bad over the last 6 months or so. And we expect it to get even worse.
Okay. You said something a while ago. COVID survivors get depressed.
They
Why
get
is that?
lethargy. Well, to be fair, we don't know yet. They get lethargy, they get depression, they get feelings of helplessness over, we're talking months after they've gotten the infection. We're not sure exactly why that's so, or whether or not they respond to traditional medication. But it is something that has been coming up in the literature. The problem with coronavirus is that every day there's a new evidence being put out. So it's changing rapidly in terms of what we understand about the viral illness. So we're just getting the information as it comes. But we really don't know why they get depressed. Most, if not a significant proportion of persons, do end up with depressive type symptoms in the long run post COVID.
I am a COVID survivor, right? And I am not depressed. What my greatest feeling is a feeling of being thankful that I survived it. You know, I am more optimistic. I'm more careful since my contraction of the disease of the virus. Um, One thing though that I've realized, well, kind of wayward from the topic now. I smell that don't smell stench. And that's like a month I had now.
Yeah,
So
but that's the
in that
thing.
sense,
We still are not clear on what the different neurological damages that have been done with the virus and how many people have the same problem. Because
yeah,
it has been a year or less, about, yeah, it's been a year now, a little over a year.
Exactly
We
1 year that
don't
the
know
UK
what's
mentioned.
going, yeah, we don't know exactly what the different situations are. We are just having to hold on as we get the new information as to what the illness causes. So it's a very difficult situation.
yeah.
And
No,
that also is why a lot of persons are fearful, because a lot of persons are fearful because they also do not know whether or not they will be the lucky ones to survive or one
yeah,
of the unlucky ones that die.
it's a
Um,
gamble.
yes, it is. And so persons are extremely fearful. And then, of course, there's the issue with the vaccines. Persons don't know when or how they're going to be able to access vaccines, or if they're going to access the vaccines, what may be some of the problems that they get with the vaccines themselves. So it's a very uncertain times, and certainly level of anxiety and fear is very, very high in our culture globally right now.
Mhm.
So, okay.
So Dr. Walcott, a lot of time people will talk, use the term mental illness, mental disorder. So for someone that is like don't know anything about mental illness, how would you be able to tell, like if they say to you, what is the term mental illness the same as a mental disorder? How would you answer that person?
Yeah, I think they're interchangeable. As I said, the issue of mental disorders is just a sickness that affects your thinking, emotional processing, and behavior specifically. So it's really a group of brain disorders, really. And they affect the areas in the brain that help you to think, process emotions, and act. And so that's where most mental disorders lie. And one of the key areas that you get dysfunction is really in the area of social functioning. So most mental disorders affect your ability to maintain healthy social connection with others, whether it's being withdrawn with depression or completely disconnected from reality with psychosis. Most mental disorders affect your social interactions.
Okay. And also, like, say for instance, if I knew someone that that appears to have symptoms of a mental disorder, what would I do if I was living in Jamaica?
Well, the thing with Jamaica is that we have a very healthy public health system, and our mental health services has been entrenched in the public health system for over 40, 50 years now. So in most health centers, most general hospitals across the island, there are mental health services available. There are over 200 and something health points of contact all across the island. Almost all of them have mental health caregivers located in those centers. So it's very easy here to have access to mental health treatment and mental health care. And certainly what you want to do is encourage the person to go to seek mental health care or assessment just to make sure and identify what's going on with them. The good thing about our mental health service is that they are at the same venues with other medical and other services. So persons tend not to feel as stigmatized because you're going to a health center rather than going to a designated area for mental illness in most countries. So for us, the stigmatization is less because they go to health centers or general hospitals for their psychiatric care.
Not really, because they put them in the back. And once you go in the corner at the back, everybody knows where you go.
Well, in some areas, that's mainly Kingston. In the country, they don't go to the back. It's town alone, and town is backward. Town is out.
Dr. Walcott, like for us here in the UK, like people come into hospital two ways. Either they're put on a section, and you have a whole host of different type of sections in the UK, or they come in voluntarily. But it depends on the ward that they're going on. You understand me? Because like for me, we have certain locked wards where if that person is going to go on that ward, they have to go on a section. Do Jamaica have something like that?
No, and we've moved away from that because that's archaic and backward. What we recognize is that the issue of involuntary treatment and locked wards is really backward. Most of our patients who are admitted now are actually admitted on general medical wards across the island. I think Bellevue have less than 700, 600 patients now admitted or so. So Bellevue is one of the, and even Bellevue is not as rigid as the UK system because there is no legal section. We have a mental health act that gives us the power for involuntary admission, but the person is admitted involuntarily. They still have an opportunity to challenge the admission within a month or so by law. And so, but most of our admissions are done in general hospitals. KPH now has, for example, the largest public hospital, has a large number of mental health patients that are admitted on wards with diabetics, with hypertensives. And most hospitals in the country also have that system. What I was pushing for when I was in charge of the community mental health was actually at-home treatment and care for acute crisis, because we have a system called the community engagement. We wrote a paper last year in psychiatric services that showed that we could impact crisis and reduce hospitalization by doing home care, home treatment care for patients who are actively psychotic. So the best area for us is to actually engage the patient in their homes and get them to voluntarily accept treatment. And you have to also remember that our mental health services works collaboratively with our patients. A lot of the issues in the UK, there's a lot of trust issues and a lot of difficulty in your mental health services because of the racial tensions that exist in the UK and other things which don't exist here. So we are able to form what we call the healthy therapeutic alliance with our patients. It is very rare that we have a patient that would not voluntarily accept treatment. Even before we were doing community engagement, it was majority of the patients would accept treatment once they're in crisis and once you use the social coercion. So the best place for patients to be treated is really at home, but in the least restrictive environment. So even general wards for medical hospitals, and we have moved away from this lockdown business that is still backward in the UK.
So one question though, the general wards, is it would it? I mean, some people would probably argue if it, if it is safe to actually have.
The issue is proper resourcing. Proper resourcing is critical, and this is where the importance of the system that we have. One of the pinnacles of our intervention system is the psychiatric aids. And they're not like the psychiatric aids in the UK or anywhere else, because our psychiatric aids are very involved in patient management. I think in the UK and in the US they use them for security mainly, but it's not the same in our situation. In our state, the psychiatric aids are very involved in the management and day-to-day interaction with the patient. They are responsible for engaging, socializing with the patient, and for getting the patients to be interactive. And so what we do is that we control the behavior with engagement rather than with coercion or sedation.
That's true.
As it can cross my path, I fling some. Well, there is a problem that work with you.
Yeah, but the UK section system is really backward, and the UK and other first world countries they have taken the route of criminalization, which is what they used to do, criminalization of mental disorders. But really and truly, it hasn't worked. It hasn't worked, and all the compulsory treatment orders have not worked because there's still overburdening of the mental health service, and the reality is that people don't trust them.
Yeah,
that's the truth.
Yes, so I was actually going back when we just started, Dr. Walcott made a point on psychosexual behavior. So I wanted to know more about that. What is psychosexual behavior? That's one question.
Psychosexual problems tend to be issues that affect healthy, intimate relations. So things like impotence, premature ejaculation, frigidity, and also some of the paraphilias or sexual behaviors that are not in keeping with normal, healthy connection to others. So there's a lot of issues in terms of psychosexual issues. And of course, in our setting, there's an issue with regards to the business of fidelity, that persons who engage in multiple sexual relations may be having some underlying behavioral problems which have caused them to not be able to control their impulses and end up in duplicitous relationships, which is what we found.
So most persons suffer from mental illness.
Well, Fred Hickling always thought that the Nuff syndrome was a sign of madness, you know. He actually did a paper on it, and he said that Nuff syndrome is a sign of madness. It's the inability to be to not be duplicitous in your life, and it's a sign of poor impulse control, which in fact it probably is.
Yeah, Harris.
Well, it depends on what you allow yourself.
Cannot throw my friend under the bus.
I think that would be because some people actually can control themselves, but they don't allow themselves to, be controlled or whatever. But
anyway,
for those who
good recovery, Aris. Try good.
Psychosexual issues are about not being able to form healthy, non-traumatic, intimate connection with others. So if your intimate connection causes distress in somebody else or in you, then it means that there's something wrong. And that's usually the problem.
Anybody else have any question for the doctor tonight?
I actually have two more, but I can go with one if time permits.
Okay.
Yeah.
So I actually wanted to know, because he was mentioning a whole lot of mental disorders, and what I wanted to know, as it relates to bipolar type 1 and type 2, how is it that you can differentiate and know which one is which?
Well, the truth is bipolar disorder is on a spectrum. And it's just a matter of severity of the manic episode. In the type 1, the person can have a manic episode. In type 2, it's mainly hypomanic. And the only difference between mania and hypomania is that in hypomania, they don't end up in hospital or jail. That's really the definition. Because the symptoms are exactly the same. It's just a matter of severity. But in most bipolar disorders, in fact, depression is the most common state. That's what most people don't get or understand. So it's a mood dysregulatory illness where the person has problems regulating their emotional state of depression and euphoria. So they go through phases. They can go through a depressed phase for a lengthy period of time. And how you know differentiate bipolar from regular depression? The bipolar disorders, they tend not to respond to medication as effectively or quickly. And most persons end up having depressed phase first. They're treated with antidepressants and they don't respond. And then shortly down the line, you can see a hypomanic or a manic episode evolve, and then you have the diagnosis. But the diagnosis is hard to make. And in fact, sometimes it takes up to 10 years before you can actually make a diagnosis of bipolar disorder. So that is on a spectrum. And like I said, the only real difference is the severity. Whereas bipolar 1, you tend to have manic episodes with the depression, and bipolar 2 is hypomanic episodes. But it's really the same. The symptoms are the same. It's impulsivity, it is reckless behavior, and you go through cycles of depression. Yeah, but it's not as common. I think the prevalence rate is something like 0.6%, despite how widely recognized it is. Everybody wants to be bipolar, but it's really not a common illness.
Okay.
Any more
Well,
questions?
what was interesting for me though when you said it can take up to 10 years to be diagnosed.
Yeah, yeah,
That
because
was
usually the persons present with either the depressive phase first, and so usually the diagnosis is depression. And in most instances, the hypomanic or manic phase is not well recognized. People just think that they are coming out of the depression and they don't pick up that it's pathological. Especially hypomania. Hypomania can be very difficult to pick up, because the person is not disconnected from reality. They are not delusional. They are not having any psychotic break. But their behavior is just impulsive. They're high energy. They tend to be very productive, and people will say that they're very engaging and charming. So it's hard for people to recognize that this is a sign of pathology. So it tends to go undiagnosed for quite a while.
Okay.
interesting.
Very interesting.
A friend of mine told me something the other day about a thing called hypersexual, I think. I've never heard of the term before. But it was associated with bipolar disorder.
Oh God, yeah, we've had great difficulty with that, especially in Jamaican men. So I don't know how to give it a definition of hypersexual
This was in a
in a
Jamaican
Jamaican culture.
woman.
One of the things that we use is what we call comparative. In other words, if the sexuality or sexual behavior is more than what is usual or what is accustomed, then it's hypersexual. But people's sexual desires and appetites vary widely, especially in our culture for some reason. So what we look for is change in behavior. So if you have increased libido, increased sexual engagement, then that's a change, and we look at that. But yeah, increased sexual activity in bipolar disorder is very common because they have impulsivity issues and they have these feelings of grandiosity or heightened self-awareness or sense of self-importance. So sexual connections tend to be very, very rampant.
Okay.
So one I need to go back to something that you mentioned earlier. You mentioned that it's usually like so well there are brain disorders, right? So would a neurologist be able to make that diagnosis?
Yeah, I mean, it's similar, but not the same. Neurologists tend to look at disorders in the brain that affect your um, movement and other brain functions. Psychiatrists focus on thought, emotions, and behavior. and social engagement. So it's not unsimilar. In fact, when we do psychiatry, we have to do a course in neurology as well, because there's a lot of overlap, but the overlap is not as complex. So no, I don't think I think they will be able to recognize, but in terms of the proper diagnostics and management, it's a psychiatrist that would have to do that.
Okay. And what is the difference between a psychiatrist and a psychologist?
Well, I think this is always complicated because a psychiatrist is a medical doctor that has specialized in the field of mental disorders, so problems in thought, emotions, and behavior. A psychologist is somebody that focuses on the behavioral sciences. So they're not medically trained, but they focus on human behavior.
Okay. Okay.
So if you recognize there's an overlap, because mental disorders also have behavioral disorders as part of the sequelae. So that's where they overlap.
Okay.
One more question from me. I just wanted to know is if bipolar disorder, if it is categorized as a type of psychosis.
It can come with psychotic symptoms, but it's categorized as a mood disorder. But you can have psychotic features depending on the level of severity. So you do have delusions, it can be grandiose, and you can have hallucinatory experiences. But the hallucinatory experiences tend to be mood congruent, which means that the hallucinations are in keeping with how the person is feeling. They are not devoid of context. So for example, a person who thinks that they are the ruler of the universe may hallucinate and see a god-like creature giving him power or something like that. So it's always within context, but depending on the severity, you can have psychotic symptoms, but they are primarily classified as mood disorders.
Okay.
Is there anything?
No. This is all new to me. I'm sorry. So I'm just listening and being in awe of some of the things that are being said.
So, Doc, I'm a registered mental health nurse. If I was coming to work in Jamaica, what advice would you give me? That's my last question.
I think it's the best place for you to work, except you won't get no money.
No money that they're England either. No money that
Yeah, that's not true. England, UK minimum wage is 200 hours. 225,000 Jamaican a month. Yeah, it's a lot of money.
Don't compare it. Don't do it.
Yeah, money is money. But the reality is in Jamaica, the majority, as I said, the majority of management really falls on the mental health nurse and the psychiatric aides. Those are the ones that actually have the management of the patients. So in essence, it's you have autonomy and you have the ability to establish a sense of control and mastery over your craft, where in England you might be overridden with supervision and following instructions. So a lot of crazy white people that don't know what they're doing. But that's a different story.
Oh God. Well, guys, we've come to the end of another wonderful discussion. I want to thank Dr. Geoffrey Walcott for taking the time out tonight to join us and to share his knowledge with us all. And we'll see you next week for another week of Up for Discussion.